Hello and welcome to Just Ask, EAO Channel's monthly rendezvous connecting professionals from all around the world. Where are you joining from today? That's my first question. I've already seen some people tuning in, and they are from Austria, from Italy, from Portugal. Per is tuning in from Norway. Asma is connected from Algeria. Andrea from Italy. Already a wealth of international people connected here for a brand new Just Ask session. My name is Hayley Edmonds, and I'm delighted to be your host for yet again another fantastic virtual rendezvous that puts you in the driver's seat. You can ask your questions to the professionals. And today, our guest invitee is Dr. Luca de Stavola. So, Dr. Luca de Stavola, I know you're connected. How are you doing? Thank you so much for being with us here today.
Thank you very much, Hayley. Super. I'm really super honored being invited to join this Just Ask session from the EAO. I'm really enthusiastic, and thank you very much for the invitation. And you speak perfectly, but pronounce perfectly my name. Thank you very much.
That's a great start. That's good to hear. So today you'll be talking about guided bone harvesting. Now, just before we get into that, just a little introduction with a bit of your background and what you are and who you are. You're a dentist, oral surgeon, international speaker, surgical coach, inventor and developer, clinical and surgical advisor. Now, that was your Instagram bio. Now, you're something a bit more studious is, you're, of course, a Master of Oral Medicine and Implant Dentistry at the University of Munster, Germany, that you practice in private offices in Padua and Treviso, Italy, dedicating your work to the field of periodontology, oral surgery, implant dentistry, and bone regeneration. And you're the inventor of the computer-guided bone block harvesting protocol, and we will get right into that in just a moment. Now, Just Ask is, of course, a fantastic opportunity for you to ask professionals your questions. So don't hesitate in putting any questions you may have in the chat, even if it's just saying where you're tuning in from today. We'd love to hear from you, and that is exactly the objective of this Just Ask. So, Dr. de Stavola, but let's get into it. Let's take a little back. Let's maybe take a huge step back. Let's go back to your background. Let's give a bit of context. How and where you studied, and how and where you studied influenced your developments and your projects later on. Now, as I just said, you've got a master's in oral medicine in implant dentistry at the University of Munster, Germany. Now, you spent a lot of time studying in Germany, if I'm not mistaken.
Yes, that's right. I spent 4 years of my life, and was a strong period because I was running the master at the University of Munster, but at the same time I was running a 4 years program at the Fuad Curie Clinic, and we were working quite hard, 12 hours per day, 5 days a week, and was a very, very strong experience, has been a very strong experience, but was a fundamental step for my preparation and for my training, and in such a way was also the background for the topic of tonight, because I was studying there how to build up the bone and how to harvest the bone. And when I started at those years, think that there was no three-dimensional images available, or the case where we had three-dimensional images was very rare. And everything was done basically on 2D images and the experience of the surgeon. So also the braveness of the surgeon in such a way, and a lot of things has to be managed during the surgery. So we learn. I mean, I had the chances to train a lot because we were performing more or less 300, 400 harvesting per year. Autogenous bone harvesting from the retromolar or chin area, and there was a strong, really strong period. But as I said, was a little bit the beginning of my story, because when I was back from those years, obviously I was still young. I mean, I consider myself still young also now, but
of course,
I was
of course.
I was definitely younger.
Doubting that.
I was obviously thinking to develop my way in Italy. So proposing myself as a teacher, as a coach, as a speaker, and this brought me to basically to performing some courses, and I would say that in such a way I was trying to put myself like today, to share my knowledges and to have moments of interaction with the colleagues. And I mean, one of these was a course with the life surgeries. And what happened that obviously it was fully of my ego, I want to promote myself, and I was teaching how to perform the diagnosis, meaning that how we should look to an X-ray. And I want to share with you maybe this picture that is nice, because that was particularly that case. You know that every time you are preparing a lecture and you have a live surgery, so the people want to see how you're doing, how you're managing, also your stress, also your the pressure on you on performing something in front of the other colleagues. And there was 40 colleagues that came for that course, and I was hosting I was guest in an office in Ravenna, and they share with me this X-ray before the surgery, and I was basically watching and explaining how we should do the diagnosis phase, meaning how we can recognize the external oblique ridge, how we can check the distance to the nerve. And I was talking about all the aspects, the technical aspect that are strongly related to this surgery. And on the same time, I would say there was a lot of ego on me, because obviously I was young. I want to show how easy or how fast we can get a bone block from the retromolar area. And always, obviously, I was giving all the guidelines to do this. But what happened? What happened that happened that I explained everything. It took me 2 hours before the surgery to say, okay, look, we are going to do this and that. We are going to manage the distance to the nerve, as the literature is telling us that we have to be safe. And everything was explained quite strongly, also because it's, I like to be precise. So I want to be effective also in the communication. And what happened that I started the surgery, and this is, since it was a live surgery, we were recording the surgery. So I have the video of that surgery, and I was performing the osteotomy lines, following the Curis protocol, basically my mentor protocol to harvest the bone. And all the osteotomy were performed very superficial to avoid any interaction with the deeper part of the bone, and then generating the fracture line, so to collect the bone block. And what happened that I generated the fracture, and I was trying to say the block laterally, and the block basically was doing like bungee jumping, coming out and going back in, because there was the nerve. There was the nerve running inside the block, because the fracture line runs lingual to the nerve. And that, I would say, were my worst 10 minutes surgery of my life. And the stress was so strong that really, I think I lost 10 years of my life in my heart, because it was very, there was a lot of tension. And now I took out the audio, but there is also the audio, and maybe I know myself quite well, so I can still realize the tension on my voice when this happened. And at the end, obviously there was the stress on me, and because I realized that there was a week of control and negative novelty and unpredictable, and obviously my ego went down. I was really, really depressed because I realized that I invest a lot of time on my training. I invest also from a business point of view to develop, to promote myself in a training center, to educate people. And then I basically realized that this was very difficult to be transmitted also in terms of responsibility, because you cannot just say, clinician, go and do, because this
yeah, I mean, I really honor your honesty here. I think that it takes real bravery in itself to kind of be able to look back and be so, you know, and show these images as an example of an error that you made, you know, and you're being so open and honest in this situation. And you know, as you said, you talk about ego, but I think it's also, you know, you mentioned bravery and enthusiasm, and I think it was more like that. You wanting to transmit this knowledge, and with all this enthusiasm that you had, and you know, no one's perfect. You know, everyone's human error is a huge issue in this in the industry. But you know, especially using a free-hand approach. I mean, I'm sure that a lot of people can empathize with this scenario, but you know, just this video is so fantastic to see, because it really, and you giving us this insight. But how did you stay so composed in this scenario? Because that's what it is, really. You really managed to stay so composed and to finish the job.
That is, I think, was a fight, because from one side there was, you know, stress is that feeling that push you to run away. One option was just run away from the room and escape, run on the street, and as far as you can from that scenario. The other was just to try to find out the solution to the problem. And I think that to solve this, my training was a crucial point, meaning because when you spend 4 years, you do things every day, you learn also how to manage your stress, because it's obvious that this was a particular scenario, there's no doubt. But when you start to do something, you have small steps of stress that you have to manage to grow. Otherwise, if you stay every time inside of your comfort zone, you never grow. There is a very nice sentence in Kung Fu Panda movie. I don't know if you are familiar with that, but there is the Master Shifu. The Master Shifu is the teacher of the panda. And at one moment, he said, if you do only what you know, you will be never greater, or you never grow more than what you are now.
Yeah.
And this is, in such a way, is also a philosophy. I mean, I don't want to be bored of my work, and I want to try to support my patients in the best ways possible, obviously compared to which are my possibilities, my limits. But I think the point is we should never stop growing. Then so you may realize that is not your part, is not something that you're going to do. But we have to try to grow, to understand better what you are doing now, and to prepare yourself for the future. So you need a small step of stress in your surgical life to grow. It's obvious that this was not a small step, was like a jump in a black hole, because was really critical from that point of view. But that was really a sort of ground zero for me, because and this to came out from this situation. I'm super thanks to a friend of mine that is the co-developer of this approach, which is Andrea Fincato. We studied together at the university, and then he was immediately involved in digital dentistry and how to place an implant guided, and more or less in that period he came to me, and he was like in a provocative way say, but why you're still working freehand? Now in digital dentistry we can do everything.
So if I've understood correctly, this the incident, this live surgery was a real turning point for you in your career, because it made you realize that you want to evolve. It gave you maybe more motivation to evolve, and of course your friend was there to help, was there to kind of give you that motivation and maybe provoke you a little. But yeah, this was quite, as you say, as I said, an important turning point in your career.
It was. I mean, he provoked me, and then we sit down and we start to see how to manage. And at the end, the solution was really relative fast, because we took, I think, 1 day to develop everything, because we understand how we could use the CAD softwares to work on the osteotomy. So just to make the story short about related to this case that was very stressful, and to jump into the other case, is that, or better, the solution of this situation was that I came out from the frustration with the potential solution. And the point is that there is no control at all when you are working freehand. You could be a super surgeon, you could have a huge experience. And this happened to me after hundreds of harvesting. So was not the first, was not the second, hundreds of harvesting. And the point is that when you are working freehand, you have a diagnostic data, and you have the surgical field, and you are matching in your mind everything. So you are the center of the accuracy of the diagnosis, and also the performance of the surgical performance. So, and this has nothing to do with something that is under control. And in a case like this, so what we want to do is basically also to control the stress. And to control the stress, you need preparation. You need to prepare yourself. It's like when you are travel to the airport, you are checking if you have the tickets, if you didn't check in online, if you have the documents, if you have everything. This is a preparation. You have to prepare yourself. And then what is important from a surgical point of view is try to anticipate the critical points, meaning that you need not just to say, okay, I would like to do this and that, but you have to prepare yourself for what I'm going to do if something is not running as planned. What I'm going to do if, the plan B, surgical plan B. But it's important because you have to focus before, because if I'm preparing a surgery as we are talking right now, then it's very easy to find out a solution, because we are not under pressure. We are not under stress. So you can be concentrated, you can think about one solution, and then go back on that solution a few days after and think, okay, is that really a solution or not? And then the other point is how I can bring control on my surgery, because if I decided I prepare the surgery, I check the critical point, now how I can translate this into the control during the surgery. And this was the background basically to go guided, to try to perform the harvesting completely guided, meaning that we can look to the defect. We can easily measure in a software how is the defect, the deficiency, define how much bone is needed, and then basically understand how we would like to cut the bone, basically, and that makes the approach very, very controlled, because it's obvious that you can select the osteotomy lines in a software, and you can try all the solution in a software. I will cut like this, like that, and I want to keep a distance, a safe distance to the nerve, and I want to get that amount of bone exactly in that area, preserve the tooth, preserve the nerve, preserve implants if they're there, and everything is running in a digital world, meaning that you can select the cutting planes, meaning that all the small planes that are running inside the bone in this video are the osteotomy lines that I'm going to perform. And I can change the position. I can change the inclination. I can change the entrance point and the deeper point. So I'm not just speculating on where I am or I'm brave today, I'm feeling good, and I'm going more distal or more mesial, I get a big piece, and the people will say, wow. This is just that is something that is done not during the surgery, is done days before, weeks before. So you are preparing yourself, and meaning that I'm going to collect this, I'm going to perform this. And then what is the digital opportunity is that you can transform this into a three-dimensional ruler. So like a ruler that we are using to draw a line on a paper, in this case is a three-dimensional. So and so this was the idea at the beginning. Then and this was 2000, between Christmas time 2011 and New Year 2012.
So just how do you go from whilst we understand the technique and of course the advantages of digital, how do you go from having that idea to developing the software? How does that transition come about? Because maybe some people that are watching aren't so au fait with the digital side of things and would like to know, whilst they may understand how to utilize it, how do you go from having the idea and wanting to develop it to actually producing that software that people are going to be using later on for surgeries?
That was another journey. I mean, it was not so stressful as as the at the surgery that time, because at that time was a lot of stress and concentrated in 10 minutes. That I would say is equal stress, but is diluted in month, because it's obvious that I think we all born as a dentist and not as a engineer or developer or businessman. So we see all the things in a very, I would say, let me say, child way. So everybody is gently, everybody's generous, everybody are going to recognize what you are doing and recognize that is your idea, that you put your efforts, your passion. But when you are going into developing and talking with companies, and on the other side, there is not a child. There is no someone is thinking in the same way as you. I mean, is thinking of doing business. So you have to switch your mind and start thinking in a completely different way, and basically protect your idea from the wrong people. I mean, sounds strange, but at the end is that we have a lot of clinicians having super idea, but then they have difficulties on bringing this idea into a real advantage for the other clinician, because you have to go through the market, the business people that they're thinking differently. I'm not saying that they are bad people, but it's just a different way of seeing the problematic. So if something is super interesting and is very useful for clinician, but you cannot build up a solid business behind, you will never go into the market. So you will never reach the other dentist.
You have a very pragmatic approach, I think, and maybe that's why they have a different approach, more of a business-minded or digital approach as well. So, I mean, maybe that's where it was hard to kind of. Sometimes it's hard to kind of transmit how and what you want to, to design. There's actually one question from Dr. Stefan Finkel, Luca Stefan Finkel from Germany here. How can you control the internal fracture line of the block using a digital approach?
Yes, that's a good point. And I think I was lucky because it's exactly next slides on my presentation.
That's a coincidence.
yeah, right. No, but I mean, it's really a coincidence. And basically, this is a guide which is bone supported. But as you are going to see in this animation, it's very nice because this ruler allowed us not to work just on the surface of the bone, but we can go deeper. I mean that I know when you are placing an implant, you know which is the depth that you're going to reach. I mean, you are going to place a 10 millimeters implant, your drill is going to drill 10 millimeters. Now, this is more or less exactly the same. So in a case like this, if I'm going to drill 7 millimeters, I need to go to 7 millimeters, I can drill to 7 millimeters. I can use the piezoelectric tools facing the interface of the guide. So following the inclination given by the guide and reaching the 7 millimeters line. And as you can see in this picture, basically you are reducing or almost in some cases avoiding a fracture line because your osteotomy lines like L osteotomy, like in this case, and you are reaching both osteotomies in the depth, so there's no fracture line at all. So you can control that, or you can minimize that line to 1 or 2 millimeters. So in 1-2 millimeters, then they are not going to run everywhere. So you can quite easily reach the target and avoid any uncontrolled area. Think that in some cases, if the nerve is very cranially based and we have enough space, we can run lateral to the nerve. So this is obviously going to expand, not just saying that we are going to do things safer. And you see that in the apical direction, you see what I mean, that you're performing the other L osteotomy, so you are reducing completely the fracture line. But you can realize before doing the surgery if it's possible to treat that patient. And this is a huge value in terms of safeness for the patient and control of what you are doing. Because nowadays, as we are going to see later on, maybe I'm going to share something, we simulate the entire surgery in a digital world, even if we're working with autogenous bone. So we are selecting all the steps. We decided to do all the steps, like when you open a Lego box and you have thousands of pieces. And if someone is telling you, okay, look, I put all the pieces on the floor and I show you the final picture and say, okay, start and build it up this. No one will be able to do that. But if I give you the box with 1,000 pieces, but I give the instruction, also my little son is able to do it. It will take 1 day maybe, but one piece after the other is going to build up everything. The point is that the digital approach in this field allowed us to prepare the surgery in each single step. And if I prepare the surgery in each single step, then I need just to follow during the surgery. I don't need to take decision into the surgery. Obviously, we'll be never 100% like that. I mean, you have to, some cases, take a decision, change something that has been decided before. But you have the chance to have a full control of what you're doing. And so if you're showing now the picture on the video, you are going to see that when we are generating the fracture line, we are generating the fracture line which is minimal compared to the osteotomy. And so you're going to have a piece of bone exactly of the dimension that has been planned. And so this is really changing completely the way and plan everything. You can plan everything, and you can decide if it's a technique that can be applied to that patient or not, if you have to change the approach, if you have to find out a plan B eventually because it's not possible to do this. And think that, again, I would say in some cases, the use of autogenous bone is not just my idea, or it's just something that I'm brave, I'm full of ego, I'm enthusiastic of this, and I'm going to take a piece of bone from that patient. But in some cases, that is the only way to get the predictability, to use autogenous bone from the patient. And so this is a super solution in many, many cases. It's not the solution for everything, definitely not, but this is a super solution.
I have a question from Per Oscar Otterstad. Do you print the 3D guide in your printer in the same material as an ordinary surgical guide?
Okay, that's a very good question. Usually what we are doing, and you can see this picture, for example, on the screen, this gray guide is a PMMA printed, but is laser centerized. And you can also print on a 3D printer. You need just to use a PMMA, so a medical material that can be applied in the mouth of the patient. But the problem is that if you are printing, for example, with the typical table printer, 3D printer, you need sort of legs that are going to be printed together with the guide. And the problem is that due to the conformation of the guide and due to the anatomy where it's going to be seated, it's very difficult to avoid a leg spot in a critical area for the guide, because or is on the side of the bone or is in the inner face where your tool is going to be faced in. So I prefer to work with the laser sinterized guide because they are printed on powder, so there is no legs needed to support the printing, and they are much more precise compared to the homemade printer, I would say, like that.
Are there any risks as to maybe inaccurate placement of this surgical guide? Would that be?
I mean, there's obviously the system is not accurate 100% as everything, because we have error on the CBCT data acquisition, we have error on the STL file generation. But when you are working like in this picture, you see that the guide has an arm, has a built-in reference point to the tooth, and you're going to see also in a video when you are placed it in, you see that the guide has a reference point to the closest tooth or to a tooth that could be the closest one, or even in the like in this case in the canine area, and is bone supported. It means that it's fixed to the bone, and so it's very easy to find out the position. And when you are working with a built-in reference point, the accuracy is super high. It means that your mistakes in average is less than 0.5 millimeter. It's obvious that if your guide has no tooth reference point, you may have an accuracy in the mesiodistal position, not in the vertical, so it's not affecting a risk for the nerve, absolutely, even if it's mesiodistally not in the correct position, but mesiodistally there could be a difference. But again, once it's placed in, and it's very easy to fix the guide, because you have these reference points, then you are facing the piezoelectric tool against the inner face, like a pen with a ruler. The only difference is that now your tool is going inside the bone, and you have those black dots on the tool that advise you on the depth that you are reaching. So everything is running under real control. And you see that also the osteotomy lines are very thin, very tiny. You see, this is the apical one. You are checking how is the correct inclination, and then you are placing you are going in with the instruments, and then there's no hammering, there's no fracture line that must be generated. It's very easy to take to luxate the block, and you have a very nice piece. And if you work right, you should have the same plane on the inner face of the guide and the osteotomy inside the bone. And that is super, because if you're looking this post-op CBCT, and you're looking the pre-op and you're looking the post-op. Look just the distance to the nerve. Look the relationship between the osteotomy lines in relation to the nerve planning and the post-op CBCT. And you see that basically we are preserving that amount of bone over the nerve that is the safe margin to the nerve. So we have really a strong control on what you're doing. And we publish the data anyway about this related to the safeness. And again, underline that we have a full control, because when you are working like this, for example, you cannot be more apical. So there's no way.
I was actually, yeah, sorry.
And sorry, this, I mean, this, the publication that we did and was published last year, and we did it with a group with University of Trento. So they checked, so it was like a blinded check on the accuracy. And if you see this green line, the group B and C, the two groups are with the built-in reference points, particularly if you are matching the CBCT data with an intraoral scanning of the teeth, you have a super accuracy on the system. So it's obvious that you are not locked on that. It's not like to work with the sleeve for the implants. You have anyway to be concentrating on what you're doing. I mean, you cannot think about playing football the evening during the surgery, because you have to be there. But in such a way, you are controlling what you are doing, and that is the crucial point. And the accuracy is there. It means that if you're planning to be 1 millimeter away from the nerve, you're going to be 1 millimeter from the nerve.
Right. I actually was going to ask if safety margin was considered in this, but you actually answered that. Mario Romadini wants to know if you have any data on the accuracy of the fully bony supported guides. Are they precise enough compared to partially tooth supported ones?
Oh, they are all. That's a good question, and thank you, Mario, for the question. Is the guide? They are not really bone tooth supported. They are guide that are bone supported with a tooth reference point. And I don't like to go completely on a tooth, because then it depends where is the tooth, where is the closest tooth, because it's obvious that you can increase the distance to the reference point. So it's always better to be fixed to the bone in the exactly area where you are harvesting the bone. Then the tooth reference point is just to have an accuracy in the mesiodistal positioning. But this is, I don't have a comparative study on this. But this is I would say surgical experience or surgical feedback.
Per Oscar Otterstad wants to know if you are designing the guide yourself and then have it produced by your industrial partner.
Yes, that we are not developing the guide ourselves, because there is software doing this. So we did it for a long time, because there was, as I told you, things that we developed this in 2011, more or less. 2012, the first case. We patented this in 2012. And then we started the development, and then the development was stopped. Then we restart again the development with a different partner. And I cannot go into the details of this story. But anyway, right now we are at the end of the story, meaning that we finished, we finalized everything. And so the software will perform also the design of the guide. Obviously can be modified in a CAD software, but the software is doing that. And then the laser sinterized print machine is a very expensive machine. So at the moment we are sharing the STL file to a company, third-party company that has these machines and is going to print it.
Thank you for that response. And please, continue asking your questions. Just ask. That's what the objective of this session. And of course, we have fantastic Dr. Luca de Stavola here to answer them. So you do continue asking them. And we've got a lot of people connected from all around the world, from Tunisia, once again, from Bilbao, Spain, Argentina, from Poland, an Italian in Norway. There we go. From Canada, New York City, Serbia, and Geneva. Once again, a question from Stefan Fickel. Luca, as an experienced surgeon, are you selecting the cases for the splint or any case?
No, I select the cases. I mean, I use personally, and then this is my personal point of view on this. The vertical deficiency more than 5 millimeters in the vertical direction, then I will work in this way. If I have a defect which is less than 5, I'm going to work with a GBR because I can place simultaneously the implants. And from literature point of view, there is a very nice paper that was published by Istvan Urban quite recently, saying that less than 5 millimeters is very predictable the regeneration. Then start to be less predictable if you go from 5 to 8 or more than 8. Then if it's more than 5, I use this approach because it's in 4 months you have the bone to place the implants, and is minimal amount of risk in terms of risk of complications. And but I'm doing this completely digitally, so I never repeat a freehand approach since we started with this, because it's again, it's too I wouldn't say that you cannot do it. Everybody can do, obviously. Free hands is a standard approach, and probably will be the standard approach for many years. But you cannot have a full control of what you are doing as in a digital approach. And I would say that you are going to join, if you will try, and you are going to join as a first point is that you are pushed down your stress level, because you are not speculating anymore on what you are doing. You are doing what has been planned. You know that where you are, and you are much more focused on the surgery. And I mean, that is a different way of working. And I can tell you, I did hundreds of cases before freehands. And when you go digitally, is not like I would say, I'm sorry for those who are doing guided surgery for implant, but when you are doing flapless, obviously you can check the position of your guide. You are going through a sleeve, and you don't have a direct view of what you're doing. If you do guided in harvesting, you are guided and you have a direct view on what you're doing. So is a full comfortable situation. And it's really a different way of working. And think that sorry.
No, I was going to say it really reduces variability as well, because with the preparation, as you said yourself, preparation, anticipation, control, you are fully prepared for the surgery before undertaking it. And this is, as you said yourself, the huge advantage of digital guides. Now, I have a Mashari Al-Damaka, I excuse my pronunciation, who asks, thanks, are there any limitations or contraindications that may change the digitally driven bone harvesting?
That's a good question. I mean, at the moment, we didn't experience something like that, except for one case that happened, that the assistant opened the guide of another patient. So this was something that was not fitting into the surgical field. But once we realized, then we everything was correct, and with this right guide, everything was running in the perfect way. But I want just again to underline that what is interesting in the process is this, that if you are going to have a case, and for example, a case like in this scenario, you have a vertical deficiency, and I'm not starting the surgery like an adventure, meaning that, okay, we open, I know that I have to build it up vertically, and then I try to collect the bone, I try to manage the case. This case is not going to be treated if has not went through this process, meaning that to check if there's the bone available, if there's no risk to collect the bone. And once this step has been established, is not the only step of the surgery. What we are going to decide is also how we are going to fix the plates, meaning that the Curie approach is based on the fact that we are going to harvest a piece of bone, a block, very dense cortical bone, and then we are going to divide the block into 2 pieces. And also this could be a stress point. So, and a little bit not under control. So what we have thought in the last period is, okay, we are able to collect the bone. We are able now, really, we have standardized the size of the guide. We standardize everything, which are the limitation, where we can reach the area, where not, because obviously here you don't see the soft tissue. So the limitation are coming from going too much on the back or too close to the lower border of the mandible. But what we have developed is also the idea that we can control also how we can divide the block. So in the digital world, we can simulate how to separate the block into 2 pieces. So I can check on my software which is the best inclination to have the 2 pieces of bone. And by doing this, obviously, again, I'm taking out something that is related to the skill of the surgeon, and I bring down to something that can be performed by my assistant. Because I know the shape of the bone, I'm going to define a guide where the block is going to be seated, and that cutting plane is going to drive my tool to separate the block into 2 pieces. So again, what is going to happen, that we are moving from surgeon experience to something that can be performed by everyone, because they need just to follow. I need just to follow what has been decided. And by doing this, you are coming from 1 piece to 2 pieces driven. So you are doing the surgery like driven by Google Maps or whatever as you're using as a navigation system, because you are driving. You are step 1, you take it out the bone, you place into the guide. Step 2, dividing the block. And then it's not finished, because again, there will be another step that we can add, another part of the game. And part of the game is say, okay, look, I want to build up vertically this case. And I know that, for example, what is very difficult is to fix the lingual lamina, because we have the tongue, we have the floor of the mouth, could be a risky point. So, but what we can do, okay, we have seen, I can collect the bone because I can plan the harvesting. I can decide how I'm going to perform the augmentation. But then what we can do? What we can do is to plan a guide to fix outside the mouth lamina, and then using this to bring it inside the mouth. So another step that is moving from surgeon experience to something that can be replicated. So basically, when I start the game, I have a sort of magic box, because I have the guide to take it out the piece of bone, I have the guide to separate the block into 2 pieces, and I have the guide to fix the lamina. So each step has been controlled, anticipated the critical aspect, and then I have the feedback during the surgery if I'm on the right track or not. So what is going to happen? That is much easier to work outside the mouth. It's like a hands-on training. It's not, you're not working on the patient. So you are less stressed. You can take your time. You can change eventually the screw length or whatever if you are not happy with what you are doing. And then you are bringing this once has built it up outside the mouth, and you are bringing inside the mouth. So you can replicate exactly the same position as planned. So we are basically, thanks to the digital approach, we are transforming something that was purely on the skill of the surgeon, on the skill of the surgeon, on the background of the surgeon, in something that all the steps, harvesting, dividing, placing, is just step by step a Lego box.
This also improves the safety procedure and the safety of the procedure as well, because you're kind of standardizing it as well, and you're making it. If you mentioned Lego and using, the surgical guides, and as these are just like utilizing and getting a Lego box with the instructions and really applying it, and I think subsequently is a lot more of a safer approach.
It is. I mean, it is, because at the end, except for the biological background, that here, this, just to have an idea, this is the bone 4 months later, so we can place the implants, and the case has been built up completely. So you are going to solve the problem patient, and you are going to do it in a relatively short time with a super low complications rate in terms of healing, but you are doing in a very safe way, because the patient is not going to have no risk for harvesting, is going not to have no risk, or all for the complication related to the wrong positioning of the blocks. So you are really, it's a full control approach, and I would say, I know that it's me, so and as a background, but the good thing, and going back to the what we said at the beginning, what makes me more happy or happiest ever is that if I say 10 years ago the people was coming for a course and nobody was doing, meaning that say, okay, look, you do great things, but I cannot do it. Nowadays, I see people starting and apply the approach. So we are giving a chance more to treat better the patient, to solve those cases that they cannot solve in another way, or they have higher risk to do it in another way, and they are getting the chances to perform themselves. And this is to me, as a trainer, as a teacher, is the best thing. Nowadays, I receive the cases through WhatsApp. We have groups of WhatsApp, as probably everyone has, where the people are sharing the case that they are doing, and they are doing the same thing I'm doing, and that's make me happy, because every time I think, when we are investing our time in training or in education, obviously we would like to have a profitable time. So you invest money, you invest time, and if you are able to replicate what has been shown, then you had invest your money in a good way. And then you are bringing something new in your office, you are increasing the chances to treat better your patient, you have a new solution, and must be a replicable solution. So, and the digital approach in such a way is not canceling all the problems related to these surgeries, meaning that you have any way to manage the soft tissue correctly, which is a huge point. But from the hard tissue point of view, you don't need hundreds of cases to be a good surgeon with this approach. So make things easier, and you are doing this with also in a positive way. I mean, you are much more enthusiastic when you are approaching a case like this, because it's going to be, let me say, like a sort of fun moment, surgical perspective, but you don't have the stress of doing, wow, I'm starting a surgery and I hope I'm going to finish this as I plan, because you are going to do exactly as you plan. And few weeks ago, 1 month ago, I was in Gran Canaria for a congress, and there was a good friends of mine that is doing this stuff. And on Monday morning, he wrote me a message, and I love the incredible, because he wrote me, "Are you safe cutting today? Like, are you surfing today?" Meaning it was like a sport, because that's the point. You are approaching the surgery with less sports, and so I'm very happy every day when I can safe cutting, because it's a positive day. It's not a stressful day.
In the chat, you've been called the Bone Builder.
Yeah.
Which is a very flattering surname. I have a question from Asma. I think it's actually a question a lot of people are probably asking themselves. How can we get the planification software?
Yeah, that's a good question. I mean, we mentioned, I mean, this is a direct question, so probably I can answer. Is a real guide application. So is a plugin on existing software for implant planning, and so once with the software you can plan. It's very simple.
And Stefan has another question. Could you give one comment on flap mobilization to close the massive augmentations?
That's a very good question, and you know that I was taking out these slides from the lecture, but I will put it in a second. Just give me a few seconds that I'm changing.
Go into your deleted pile and put it back in
right.
to answer the question. In the meantime, thank you so much, everyone, for asking your questions. We do have a bit of time left, so please make the most out of it. Because we do have, of course, have the fantastic Dr. Luca de Stavola with us today. I was about to say this evening, but it could be morning or afternoon, wherever you're connected from in the world. So back to Mr. Dr. Fickel's question about giving a comment on flap mobilization to close the massive augmentations.
That's a good point. And I have these slides, which is not as light as a video. If you are looking on this video, you see how the flap should be at the end of your surgery, meaning that there is still no horizontal mattress stitches and the flaps are there. Now, to go there, there is for sure two crucial points. One is that you should elevate your flap, but not just in terms of periosteum releasing incision, but you should also, and which is very, very important, is to elongate the flap remaining over the muscle level. So periosteum releasing incision is one point, but the second point is to try to have a longer flap without involving the muscle. And this is going to make your flap quite light, so not heavy, not too much retention. And the other point is that once you have elongate the flap, and you don't need to have 3 centimeters, 4 centimeters longer flap, because the risk in wound dehiscence is not related to the length, is relating on the force you are applying to keep the flap in position. So maybe you need less flaps that are shorter, long enough but shorter. You don't need 3 centimeters of flap. And then you have to do this. You have to place internal breaking force stitches. Think that all the surgeon, plastic surgeon, if you think aesthetic surgeon, wants to avoid the tension on the final suture line, because these can bring a scar tissue, visible scar tissue. So if we are working with internal breaking force stitches that are not involving the entire thickness of the flap, you are going to absorb the tension because you are bringing the two flaps coming together, but without having ischemic effect. So you see that on these two videos, you have the initial situation when we are placing these internal breaking force stitches and before placing the horizontal mattress sutures on the right. And you see that there is no tension anymore. Think that this suture placed before the horizontal mattress stitches is absorbing almost 90% of the tension. So your risk of complication during the healing phase is going to go down dramatically. So this is still not digitally guided. So we have to think about this step. We have to do also here, there is a rationale. There are measurements that can be taken to simplify the approach to be replicated and repeatable. But basically, these type of suture are avoiding any wound dehiscence, and this is going to change really your life in terms of soft tissue management. At least that happened to me. And again, I came through this because my anesthesiologist, there is a story for everything, but my anesthesiologist is working a lot also with plastic surgeon and aesthetic plastic surgeon, face surgeon. So, and we were discussing during surgery on the fact that I was trying to have a passive wound closure. And he say, look, plastic surgeons are working with this and this tips just to reduce the final tension. And basically, when I started, and I started more than 10 years ago, that changed my life. I came from 15% of wound dehiscence, which is the typical incidence of complication reported in the literature, to 1%. So is again another strong point.
So 10 years ago, 11 years ago, when you were performing the live surgery, and if you'd have said to yourself then, you know, what you know now and where you are now, what do you think you'd have said? What do you think, how would you have reacted knowing that 11 years down the line, you'd be producing software that is going to, you know, digital software that is going to help people all around the world with this surgery?
Wow, that's a good question. What I would say, first of all, I wouldn't believe, because my first reaction when Andrea, my partner in this adventure, he said, why we cannot do surgery guided? And I say, it's impossible. That was my first answer. We cannot do it. I was too fixed on what was a freehand approach that my first answer was, it's not possible. And that could be also my answer today, thinking, or better, those days thinking about today will be not possible. But I think that every time, at least, I realize that you must have an experience of an uncomfortable situation to find out a solution. Because if you are still inside your comfort zone and nothing is affecting your comfort zone, you see no necessity to change. And the change is coming out in the moment that you are feeling uncomfortable, that something went wrong and in your comfortable routine was not expected. And then if there is two ways on seeing this problem. In one way, you could say, okay, that was an exception. That will never happen again. And you keep going in the same direction. Or you start thinking, okay, wow, this was totally unexpected. This cannot happen again, must not happen again. I don't want to be again in that situation. And you start changing. But I think is also in such a way is you must have a mindset on this, because there is I realize that there's a people that would like to learn something, understand when is going to be applied, and just remain on that track. And then there is people that must changing continuously what they are doing because they see problems everywhere, even if there's no problem, or better, if there is no strictly a critical point, but they want to change because they think that this way will be better, and this will be faster, and this way will be easier. So, and we must have these people, because these people are changing the track for the others. And I don't know if this is going to change the track for the others, but at least change it for me. Every time I say that the first customers of these technologies is myself, because I do things to solve my problem. Then if I can be useful also for the other, I'm more than happy. Then is super.
It was a fantastic lecture. Thank you so much, and keep inspiring. I guess that's the thing. You're so benevolent. There's a real element of benevolence with it as well. And you know, the character from Kung Fu Panda can't be wrong. If you don't take risks, then you're right. We don't evolve, and that's exactly what you've done. You've taken a risk, and the results have been fantastic. So thank you so much for your time tonight. Thank you, EAO, for this Just Ask session. Thank you for everyone for joining us. I'm going to just give a few shout outs. Federico, Jose, Per, Asma, Andrea, Mario, Giuseppe, Natalia, Oslem, Francesco, Rida, Alfonso, I mean, Mario. We've had so much interaction tonight. It's been a fantastic lecture, and it's so great to have so many comments and questions from everyone that's taking part. Thank you once again, Dr. de Stavola.
Thank you very much.
For your time. And just to kind of conclude this, the EAO Congress is holding a joint meeting with the GGI, the German National Association, and it will be held in Berlin from September the 28th till the 30th. Don't miss the latest updates in implantology about innovative technologies and treatment strategies, and enjoy great networking opportunities, of course, with your colleagues. Join us and register before June the 15th to benefit from an early bird rate. And registration is free for student members. It's only €99, obviously, we're just saying. And all of the information is in the description box below. Once again, thank you, Dr. de Stavola, and I will see you on June the 5th for our next session with Dr. David Noret on guided full arch implant surgery. Same time, same place. Thank you very much. Have a lovely morning, afternoon, evening from wherever you are in the world. Thank you so much.
Thank you very much.
Goodbye.